Okay, everyone, so we are now going to cover pathology. And remember, pathology is one of the big five. So the thing about pathology, it's kind of grouped with microbiology when you are covering your sections. And so make sure you also watch the microbiology video and go through those questions as well. I think in general, there's about 60 to 66 questions that cover both micro and pathology. So you're gonna make sure that you cover all of it, okay? So a couple things here. When we start out with just pathology, it's a huge section. So I'm going to point out high yield stuff, low yield stuff. So if you see me just skipping a section, still go through it, but it's just not one of those things that we feel is important to like walk you through it step by step. Okay? So let's start off with pathology, start of the chapter, and we talk about inflammation. Now, the thing to remember with inflammation is that it's not a bad thing. Our bodies need inflammation in the healing process. There's a couple things I want you to know to differentiate the two. So the first one is acute inflammation. Acute, and then we're going to talk about chronic. But acute inflammation, just to start off with, it's the thing that happens immediately, okay? You twist your ankle. This is going to happen 1 to 2 minutes immediately post-injury, all right? Now, the same thing happens every time in acute inflammation, and I want you to know them. So just highlight there, number one, you're going to get vascular size changes. So let's say I'm walking around and I trip and I sprain my ankle, okay? The first thing that's going to happen is that you are going to have vascular size changes to that area because you're going to need cells to come and heal it. So think of it as a big river, right? Big river can carry more particles, in this case cells, okay? So then the next thing is that big river, that big vessel is going to cause vascular and structural changes around the area. So you get structural changes. That's number two, excuse me. And then number three is, this is important. Make sure you know that the cell type coming to the rescue here is neutrophils, those PMNs. All right, that's important because when we get to chronic inflammation, the cell type is different. Okay, so happens the same way every time and in the same 3 steps that we just talked about. Now, chronic inflammation is different. Chronic inflammation does not go the same way every time, and it also can be weeks, months, years. So what we're talking about here is a couple things that do happen that we want to make sure we know about, okay? So here's the 3 things for this. The first thing is that this has a different cell type. If you look there, I want you to make sure you highlight the cells here are macrophages, lymphocytes, and plasma cells. And again, what was the one for acute inflammation? Neutrophils, right? So different cell types, okay? That's a big deal. The other thing is that you're going to have tissue destruction. One thing that's important here is that when you have chronic inflammation, it gets better, worse, and so you have tissue destruction that takes place. And we see that a lot like in rheumatoid arthritis. Those patients with like the big knuckles, those are areas that have been damaged, and we can see that on our patients. And then the last thing is that you have neovascularization. So new vessels trying to come in to give oxygen to the area that has the inflammation. All right? Now, go back thinking about chronic inflammation, and there's one thing that I want to slip in there too, and that is granulomatous inflammation. All right? Granulomatous inflammation is like when those big old macrophages come in and they wall off something in our body. All right? And I put some examples there for you. You have bacterial like TB. If you have TB in the lungs, those big fluffy macrophages try and go and wall off that area of the lung. Or you have fungal like histoplasmosis. Foreign bodies like sutures, sometimes you get keloid scars, those are macrophages. And then sarcoid is a good example of just an unknown disease state that also is a granulomatous inflammatory state. All right. Now, when we talk about inflammation, there's some things that are going to affect our wound healing, local factors, systemic factors. One thing that we talked about in both the acute and chronic is blood flow. All right. So if you have a decrease in blood flow to the site that is wounded, obviously you're going to have a decreased rate of healing. All right. Other things that compromise our healing are diabetes. Diabetes causes smaller vessels as well as your inability to fight infection. Immunocompromised states, so if somebody has HIV or they're on chemotherapeutic drugs. Also, anytime that somebody is stressed or on steroids also chronically can cause decrease of wound healing. Let's move on now from inflammation to cellular disease. So cells need oxygen. And when we talk about cellular disease or cellular death, it's basically that these cells are not getting enough oxygen. So we have reversible and irreversible cell death. All right, reversible cell death basically means that the lack of oxygen causes a decrease in ATP production. And you'll learn about this in biochem too. But when you have a decrease in ATP production, you're going to have a decrease in pH, so that cell gets acidic, and you're going to have increased edema in the cell. Those are the two big things I would know. But when that happens, then things just don't flow within the cell, and it starts to get big edematous. But if oxygen returns to the cell, ATP can move again and the cell gets back to normal. All right, same thing, like an example of this would be like if you go running for a long period of time and your muscles just start to ache, you sit down, they start feeling better. It's because those cells may not have been getting enough oxygen, all right? So let's say that the cell never gets oxygen. Well, what happens then is that it gets edematous. When that happens, the contents that are needed for cellular function start to leak out of the cell and it dies. And that's called cell death, ischemia, or necrosis, all right? Necrosis is basically cell death that's not programmed cell death, which is called what? Apoptosis, right, and the definition's in there. But necrosis, there's actually four types of necrosis that I want you to know. I would know basically the type of necrosis and where it's located. So for example, the first one is coagulative necrosis. Now coagulative necrosis, coag, you think heart, blood, and that's basically what it is. It's basically when myocardial cells die, so you have a heart attack, all right? So coagulative necrosis, think heart attack. The next one is liquefactive necrosis. Highlight, circle the L in liquid, highlight the F in factive. It's found in the lung and it's usually caused by F, fungal, liquefactive necrosis. The next one is caseous necrosis, and the time we see this the most is like in TB. And you go in there and you do a bronchoscopy and you pull out this cheesy, yucky stuff, caseous necrosis in the lung, think TB. And then fat necrosis, again, just death to fat tissue, which unfortunately is not apoptosis, which again, you can read that paragraph, all right? Okay, so let's move on to some very, very high yield stuff. We're going to start talking about our hypersensitivity reactions, all right? Now, there's 4 hypersensitivity reactions that I really need you to know. They're all important, and you, I guarantee, will be asked a question somewhere along one of the 4, all right? How I remember the order of them is the acronym ACID, A-C-I-D, okay? A standing for anaphylactic, C standing for cytotoxic, I, immune-mediated, and D is delayed hypersensitivity. All right, so let's break this down and talk about each one. All right, so the first one is anaphylactic. Now, type 1 happens first and fast if somebody has an allergic reaction. And this is exactly what you would think about. This is somebody who's allergic to peanuts, or they go outside and they have itchy, watery eyes because of allergic rhinitis and hay fever. This is also someone's allergic to penicillin and goes into anaphylactic shock. Those are all falling into this anaphylactic type 1 category. Now, the response usually happens within 30 minutes of inhaling or breathing in the allergen. So what I want you guys to know is to be able to tell me who the major players are in each one of these hypersensitivity reactions, and then give me a clinical example of each one, all right? So this first one, the player here is B lymphocytes and IgE antibodies. Take a look at this visual. All right, so what happens here is an allergen activates a B lymphocyte, and when that happens, IgE antibodies are produced and bind to the surface of mast cells and basophils. When that happens, then you get histamine released from these mast cells and basophils. And what does histamine do? It gives you itchy eyes, watery eyes, bronchoconstriction, and even that anaphylactic shock. So let me give you a clinical example of this. So my husband, Kyle, he's the one that you guys see on like immunology. Yep, he's my husband. So when we first got married, he's like, I'm allergic to bananas. I'm like, no one's allergic to bananas. So I would sneak bananas into his food just to see what happened. I'm like, I'm medically trained. I can handle this if it goes bad. But yes, so there he goes. And he starts, and he can't breathe. And he's like, I don't feel good. I'm like, okay, maybe you're allergic to bananas. So anyway, that's an example of an anaphylactic type 1 hypersensitivity. And yes, I don't recommend doing that at home with somebody that you deeply love. So anyway, let's move on. Cytotoxic. Cytotoxic, let's just break down the word. It's cell toxic, okay? That's our type 2. That's the C in acid. So this is two players here, and it's IgG and IgM. I think of it as GM, grandma, okay? Grandma. And I think of it as grandma because what happens here is you have IgG and IgM, and cell toxic means that some cell is going to come into your body and it's toxic to your body. So what GM is going to come do, it is going to come and try to kill or damage, get rid of that bad cell that's entered your body. So how I think of it as grandma, I think of it as my grandma growing up in Nebraska. She loved her garden, right? Here comes that stinking bunny. Bunny hops in. Grandma, GM, is not happy about that bunny, and she tries to shoot it out of her garden, all right? Does she hit the bunny? Maybe, maybe not. But you can definitely see where the shot is around because it has damaged her garden. In the same instance, it is going to damage the tissue where the IgM, IgG has bothered, all right? So an example of this would be erythroblastosis fetalis, or Rh disease. What that means is that when I'm pregnant, I'm O negative blood, and I have a baby, and if that baby is O positive blood and they mix, my body will see that cell as an enemy and try to get rid of it, okay? That's why we get shots called RhoGAM to make sure that that doesn't happen. If it does, it can cause that baby to pass away before birth. All right, another example is rheumatic fever. Strep comes in, lands on the heart valves, our bodies try to get rid of it, and in fact, it hurts our heart valves, okay? Cytotoxic, IgM, IgG, very important, all right? Next is immune complex mediated. Now, immune complex mediated is the I in the acid. Also here, what is going on is we have our own issue, our own internal battle with our own antigen-antibody complexes. So here, nothing's entering the body, but a great example of this, for a clinical example, would be lupus. Because what happens in lupus is lupus, remember, has these anti-DNA antibodies. Our whole body is filled with DNA, right? So we have these antigens that go and they try to find these DNA and they fight it, all right? So what happens in our body then is you get destruction of things like the heart, the liver, the kidneys. You get the mylar rash on the skin, anything where this battle of this antigen-antibody complex is going on, all right? So the last type is delayed or cell-mediated, or type 4, all right? Here, this is when you have those T cells, okay? That's the main player, those memory T cells, which are going around and trying to find an antigen, and when it does, it releases leukocynin, causing macrophage activation. All right, so how I think of this is sort of like a TB test, okay? When you have a TB time test, you go and you get the tuberculosis mixture under the skin, then you have to come back 48 hours later to see if you have a wheal, okay, or a red area. Well, why you have to wait is because if those memory T cells have encountered TB in the past, it's going to float around and those little T cells are just looking for that TB. It's sort of like a little cop with a wanted poster, and that cell is like just looking for that TB on the wanted poster, okay? And it's like, oh wait, I found it. Sirens go, leukocynin is released, macrophages, you get that big fluffy wheel, okay? And that would be a good example of a delayed T cell type 4 reaction. Those are all very important. Make sure that you go and cover those and make sure you do the flashcards on that as well. So let's talk about our periodontal diseases next. Obviously very important to you guys. So the first thing we're just going to talk about is gingivitis. Now, the thing to remember about gingivitis, it's obviously inflammation of the gingival tissue, but there is an absence of clinical attachment loss, okay? So what does this look like? You get erythema of the gingival tissue. You can get some edema. If you bother it, it can start to bleed. You can have calcium buildup, plaques, and it can come over a long period of time or a fairly short period of time, depending on obviously the patient's hygiene here too. So if we talk about gingivitis supragingially, it usually is an aerobic bacteria, and it usually goes from gram-positive. The farther you go down, it becomes more gram-negative. It starts more as a facultative anaerobe, and then again, the farther it goes down, it becomes strictly anaerobic species. All right, that's what you need to know for gingivitis. All right, let's move on to periodontitis. So here, again, it's also another inflammatory tissue state. So here we're talking about a disease process that affects all of the periodontal structures. It can cause then destruction and attachment of the apparatus and development of periodontal pockets, which obviously is not good. So being a chronic inflammatory disease, guess what's going to happen? You have this inflammatory response that again causes what 3 cells to come in? Yep, you're going to get leukocytes, as well as T lymphocytes and plasma cells. You also, though, having an acute phase of this, will have some neutrophils as well. So basically characterized by a loss of clinical attachment due to destruction of the periodontal ligament. I would highlight that, okay? Destruction of the periodontal ligament. And then, of course, then you get loss of the adjacent bone structure to this. So there's some diseases that you do want to think about when you're when somebody has chronic periodontitis. Make sure that you're thinking about diabetes. Make sure that patient does not have hyperglucose. Make sure that they don't have some immune system disorder or they're not immunocompromised, as well as environmental factors can cause this too. Highlight there, smoking. Smoking is a big thing that can decrease immune function and therefore cause more chronic inflammation, especially with this disease. All right, we can also then talk about aggressive periodontitis. All right, here basically this affects people who are healthy. All right, so they don't have anything systemic pathology that you would think causing an extra inflammatory process. This tends to have a familial factor, so you're going to want to ask about if the patient has any family members with periodontal disease like this. There's a rapid rate of progression, hence aggressive in the name, aggressive periodontitis, as well as there are localized and generalized forms of this. So localized periodontitis usually has a circumpubertal onset. So what that means is that it's going to affect those permanent first molars. All right, generalized still affects people under the age of 30, but patients can be older. And again, this is a generalized interproximal attachment loss. So it can affect 3 permanent teeth other than the first molars. So I would be aware of that as well. The next one we're going to talk about is necrotizing periodontal disease, and this is one that patients do have some sort of systemic health issue going on. All right, so versus aggressive periodontitis with no systemic disease, these patients are in patients who have HIV, malnutrition, they're immunocompromised for other reasons, maybe they're on high-dose steroids, and these can be further divided into 2 categories. So check out this visual. So these patients with necrotizing periodontal disease can go 2 ways: necrotizing ulcerative gingivitis, which is NUG for short, or necrotizing ulcerative periodontitis, NUP. And these 2 diseases actually the same etiology, clinical signs, except for that NUP does have clinical attachment and bone loss. So I would be aware of those differences for your exam. All right, let's move on to rheumatological diseases. And when we talk about rheumatological diseases, we're going to hit up the autoimmune diseases first. You're going to see a ton of patients who have these different autoimmune diseases, and I want you to be aware of them. So when you think about autoimmune diseases in general, just remember that they happen to women more than men. So any test question where it asks about the patient, what they look like, appear like, make sure that if a female is a choice, that you pick that. All right. But the first one here is we talk about lupus. All right. Now remember, lupus is what type of inflammatory reaction? It's a type 3, right? Immune complex mediated. Okay. So let's talk about this just a little bit. Again, women greater than men. When you look at that, it's like a 10-to-1 ratio. So just highlight that. Also, if you see the word mylar rash, that's a buzzword for lupus. That is a classic finding that you see in these patients. Also, what I want you to highlight here is they have those positive ANA antibodies. Highlight that. That's important as well. 90% of these patients have joint pain. They also can have photosensitivity, arthritis, renal disease. They can have a list of other things, but big picture, mylar rash, women greater than men, ANA antibodies. All right, let's move on to rheumatoid arthritis then. Rheumatoid arthritis, again, immunocomplex disease. women greater than men here too. This usually happens in about the 5th decade of life. And what happens is these patients, they get these chronic bilateral small joint pain, all right? And they are super stiff when they wake up in the morning. And as the day goes on, they feel a little bit better. That is a lot different than osteoarthritis, which is big joint pain that hurts worse at the end of the day. These are bilateral symmetric, again, women greater than men, and these patients have a positive RF test, okay? They have a positive rheumatoid factor test. I would know that as well. All right, let's go down to Sjogren's syndrome. Sjogren's syndrome, obviously a big problem here because they have a classic triad of what? Dry mouth, dry eyes, arthritis, all right? This dry mouth, basically what happens here is you have all this lymphocytic infiltrates, and that's going to replace good, healthy epithelium, and that's what causes the dry mouth. So I would be aware of that. All right, sarcoid and ankylosing spondylitis, you can read through those. I think those are more low yield. All right, we're going to still stay in this rheumatological conditions, but we're going to move on to vascular disorders. And in here, we're going to talk about temporal arteritis, or it might be called giant cell arteritis. And basically, what happens here is this is a systemic vasculitis that causes inflammation within a vessel, all right? And when you think of a patient who comes in, they're usually in their 50s or older, and they complain about jaw claudication or jaw fatigue. They also complain about scalp tenderness. And what's going on here is that they have claudication of the vessel that's causing that inflammatory pain. All right, this is also, I would highlight there, is associated with polymyalgia rheumatica, so be aware of that. Lab tests that need to be done on this patient, I'd be aware of that too. So your inflammatory markers, all right? So you're gonna have your ESR, C-reactive protein, I'd get a white blood cell count as well. And then treatment, you have to get steroids on board. All right, steroids. Still, the main, the gold standard of testing is a biopsy of that temporal artery. Not something you're gonna be doing in your office, obviously, but something you wanna be aware of for your boards. All right, let's move on from there. Let's go down to erythema multiforme, and this is an acute immune response condition, usually because of HSV, the herpes simplex virus. Okay, I would highlight that, be aware of that. Also, medications can cause this, like penicillins, barbiturates, and the classic thing here is you get this bullseye lesion, all right? Bullseye lesion, erythema multiforme, think HSV as well as drugs, all right? Next is pemphigus vulgaris. And basically what this is, it's an autoimmune disease that causes severe blistering of the skin. All right, and this is within the epithelial layers. I want you to know that it's caused by an IgG antibodies directed against the desmosomes. I would highlight that in there, okay? IgG antibodies directed against the desmosomes. And what happens here is you get these blistering of the skin. And there's a test here that I would have you write off to the side, and it's called Nikolsky sign. It's Nikolsky sign. And what that means is if you put fine pressure right over that blister, it's going to move the skin and make that blister or that sore to pop. All right, that's Nikolsky sign. All right, similar to this is bullous pemphigoid. All right, bullous pemphigoid is, again, it's an autoimmune disease, and it again has that blistering skin, but it's just a little different in that there's two hemidesmoidal proteins within this epidermal junction, and basically it separates from each other. Okay, so again, the entire epithelial layer in the dermis, it basically is separating from each other. All right. All right, next we're gonna do oral lichen planus. And now this is, I want you to highlight chronic, inflammatory, and idiopathic. We just don't know what causes it. But it does appear to be a T-cell mediated inflammatory disease. So what you get here is basically white reticular pattern with multiple lesions. They're bilateral. And you can also get striations that cause this lacy network that's called Wickham's striae. And I would highlight that. Okay, Wickham's striae on the buccal mucosa, the gingiva, the alveolar sulcus, and the lower part of the lip, all right? Again, no known cause, no known cure. So be aware of that. Now let's talk about some other rheumatological disorders, and this one's gout, all right? Gout is finally something that we consider more men than women, and basically it's because gout's caused by what? High uric acid levels. And where do we get uric acid levels? Mostly is determined by our diet, so red meat and beer. Maybe hence why more men get it. But anyway, high amount of uric acid levels then cause uric acid crystals. When those crystals combine, they can get stuck in our synovial fluid in our joints and cause immense pain. I've seen more men cry because of gout in their big toe than having heart attacks in terms of how painful it is. So super painful, big red hot joint, again, most likely places the MTP joint, all right? Next, we're going to talk about diseases of immunodeficiency. And I think the big thing to know is that when you have immunodeficiency A, that IgA is located in the tear film, in the saliva, and in the mucous membranes, and in breast milk. And so if you have a deficiency of that, you're just going to have more infections or be more prone to infections in those areas, all right? So just highlight IgA, highlight tear film, and right off to the side, saliva, respiratory secretions, all right? So let's go to HIV. This is a section that will be asked on your test. I've seen multiple old test questions that stem from it, so I want to make sure that we hit this heavy and that you are very familiar with HIV, all right? First of all, I want you to know that HIV is actually an RNA virus that uses reverse transcriptase to become a DNA virus within the cell. That's crazy. That's also why it's so hard to treat, all right? So any medications that we use to treat this are reverse transcriptase inhibitors, all right? So it starts as an RNA, goes to a DNA virus within the host cells. Now, they may ask a question about how you get it, all right? You can get it from fluids in terms of secretory fluids. So breast milk, serum, like blood serum, semen, sexually transmitted, amniotic fluid, so mom can transfer it to the baby. You cannot get it through saliva, all right? So I would be aware of that because they've asked questions on that in the past, all right? So the other thing I would know is that when you first have the HIV virus, you kind of feel like you have the flu or mono. So you can have a fever, anorexia, weight loss, just some aches and pains, just don't quite feel well. Boards for you guys will describe that as looking like mono, so I would be aware of that. The other thing you need to know is the cells that it affects. So it's going to affect your CD4 T cells, okay? This is a big deal because we all have thousands of CD4 cells in our body ready to go and fight infections. But if those numbers are decreased, then obviously we can't fight infections, and that is what we tend to worry about with our HIV patients, are opportunistic infections because our T cells just aren't there for us to fight them off, all right? So when our CD4 count gets down to the number 500, there was just a study released that that's when we should start prescribing medications to prevent some of these diseases that I'll talk about it in a minute, all right? But the magic number in terms of CD4 count, when we change the HIV definition to somebody who has AIDS, is 200, all right? When their CD4 count gets low enough to 200, that patient no longer has a diagnosis of HIV, but they have the diagnosis of AIDS. I'd be aware of that too. Now, if we're screening somebody for HIV, there's two tests I want you to be aware of. It's the ELISA test and then the Western blot test. And we do them in alphabetical order, if that helps you remember which one's first. ELISA, then Western blot. If both of them are positive, you have a 99.9% specificity of having the HIV disease, okay? So in terms of, again, HIV, people don't die of AIDS, they die of the opportunistics they get because they're so immunocompromised. So I want you to be aware of those diseases I have below. So the first one is pneumocystic pneumonia. That is a very classic opportunistic infection you need to be aware of in the AIDS population. They also can get parasitic infections and fungal infections like toxo and plasma and histo infections. TB, very common. The other one I want you to be aware of is, look at that fourth bullet point down, Kaposi sarcoma. This is something I would be aware of because they can get those anywhere in the mouth, in the skin. It's actually caused by herpes virus number 8, all right? So be aware of that as well. Also, hairy leukoplakia, that involves the borders of the tongue, and anytime you think of hairy leukoplakia, you need to be thinking of HIV positive patients. Okay? All right. Also, herpetic lesions. These patients have big problems with herpes lesions, and again, those can cause big time problems in the mouth and the sores for the patient. All right, so lots on this. Let's just take a break and look at this question.